Hi, Dr. Rajat.
Hello, ma'am. Good evening, ma'am.
Good evening. Would you like to try share and see if your slides are working fine so that we don't waste time that time?
Okay, ma'am.
Yeah, just a second and then I'll give you an access now. Dr. Rajat,
Yes, ma'am.
can you share your screen slides and we will just check once.
Okay. Ma'am, is it visible? Hello, ma'am.
Hello.
Is it visible?
Yeah, it is visible. Can you put it on slideshow?
Okay, okay.
No, just click from beginning here. Yeah. Can you change the slides? Okay. I think we are ready. Okay. Thank you.
Welcome, ma'am.
We'll wait for another 3-4 minutes before we start. So good evening, everyone. Welcome back to my channel, Learn with Dr. Akshata. So here today we are in the second webinar of the series, Rheuma-ID Crosstalk series. So today we are going to talk on vaccination in immunocompromised hosts. So in this session, we'll have vaccination strategies in HIV, followed by vaccination recommendation in autoimmune rheumatic diseases. So these are essential conversations in clinical practice. So we look forward to discussing the best practices and controversies and practical decision-making pearls with all of you. So again, I would like to thank all of you who have joined here today. And don't forget to like, share, and subscribe for further content. So without any further ado, let's start with the first session, that is vaccination in HIV. So I have a short pre-test for all of you. So I would like all of you to join this on VVox. So just you can scan the QR code or type in vvox.app in the Google and enter the code 173177284. I hope you guys are able to join in. Are there any issues? Okay, 2 of you have joined. So just scan the QR code or just type in the Google vvox.app. So, and then enter in this code 173177284. And you can start using the poll. So I just want to know, it's a icebreaker sort of thing. So do you prescribe vaccination in HIV patient? So yes, no, sometimes. I'm not a prescriber and I don't handle HIV patients. Let's see while we are waiting for many others to join. Okay, let's just close here. Okay, most of you do prescribe, so I think my job is half done. Okay, I'll be catering to the other half of the population then today. So the next polling question. So if you are, so many of you said you are prescribing vaccination in HIV. So let's see. A 29-year-old with HIV presents for routine checkup. She's on a stable ART with undetectable viral load, CD4 of 550. She has no other health issues. She asked if she should receive any additional vaccine as a part of HIV care. So, which vaccine will you recommend in this patient? Slightly controversial question, but we will discuss it later during the session. Okay, half of you have responded. Another 30 seconds. Okay, let's close the poll here. Okay, most of you are saying HPV vaccine, yellow fever vaccine, some of you saying MMR vaccine. Okay, let's have a look during the session. Next poll. So for those who have joined newly, just you can scan the QR code on the left, or you can just type in vvox.app and type in the code. A 38-year-old female with HIV presents to your clinic for routine checkup. She is on ART for past 4 years with good adherence. CD4 is 700, viral load is undetectable. She is inquiring about vaccination against pneumococcal, as she has never received the vaccine. So what is the most appropriate vaccine recommendation in this patient? Okay, let's close the poll here. Okay, admits only PPSU 23 and the people are divided between the first and second option. Okay, next question. Okay, sorry about this. I think there is some error. We'll move to the next question. A 39-year-old male with HIV seen in for routine follow-up visit. He is on TLD undetectable 700 is a CD4. His immunization history is unclear. He's planning a trip to rural area in sub-Saharan Africa and asks about the necessary vaccination. So what vaccine recommendation is most appropriate for this patient? So nowadays we are having, HIV, we have got a very good regimen. So most of your HIV patients are going to be well off and they do travel. So you may have these complicated scenarios. Okay. Let's end the poll here. Administer yellow fever and live polio vaccine as live is safe in more than 500. I aid A and B. Okay, people are confused. Good thing. So let's try to clear it in the session. The next question. HIV 350, CD4 of 350, viral load undetectable. He has 2 doses of modified vaccine Ankara, that is your monkeypox vaccine, intradermally 28 days apart in September 2022. He had 2 male sexual partners in past 3 months without consistent barrier protection. He asked if he's still protected against mpox and whether he needs another mpox vaccine. So those who are not able to join, just scan in this code or just type in vvox.app in the Google and type in this code 173177284. Okay, let's end it here. No additional dose. Okay. And the last question, a 45-year-old male with well-controlled HIV CD4 of 600, viral load undetectable, on ART and has been stable for several years. He has history of asthma, no history of chickenpox or shingles in the past. He inquires about shingles vaccine. So what is the appropriate recommendation in this scenario? So Zostavax, Shingrix are the two vaccines. So Zostavax is a live vaccine. That's the clue. Okay. The last question and then, okay, we'll just end it here now. Shingrix, 62%. Okay. So let's start with the session then. So vaccination in HIV. So I hope my slides are visible. Okay. So the vaccination, when you look for the guidelines for the vaccination in HIV, there are like specific guidelines is mentioned in British HIV Society, HIV Association, which has a guideline given in 2015. Then there is guidelines for prevention and treatment of opportunistic infections in adults and adolescents with HIV. This is a CDC and WHO joint document which keeps gets updated. And then in the Indian context, we have national guidelines for the HIV care and treatment, which they very briefly mention about some vaccines. And then we have the recent Indian consensus guideline on adult immunization. So these are the documents which you can get some overview about the HIV vaccination. So why should HIV or retroviral disease patients receive vaccination? Again, as we all know, HIV is an immunocompromising state where the patients will have lower CD4 counts, hence they are at very high risk of infection. And so we should have therefore a very low threshold for vaccination. And also they are at high risk of severe disease. So even whatever the apart from the usual recommendation of adult vaccination, they may require other vaccination per se because of the HIV. And there will be improved prognosis if you put the patient on appropriate vaccine, especially in scenario of the travel. So what are the concerns? So why aren't we vaccinating HIV patients so frequently as we are like the vaccine uptake in general for adults is less, but in HIV it is even more very I would say almost negligible. So what is our concerns? One of the major thing is because they are having lower CD4 counts, we are worried that these vaccines are no longer effective, like they have reduced immunogenicity. But it is there are various studies which have shown that on immune restoration, the immunogenicity will improve, and also we can overcome this by giving higher and more frequent vaccine doses. And definitely one of the concern is lack of awareness about vaccination. So what are the things you should keep in mind when you're giving vaccine to an HIV patient? So basically the age, the CD4 count, what is the risk of infection, and what are the concurrent medical conditions or the medications the patient is on. So this is a very important table. Like basically the patients of HIV, based on the CD4 count and the age of the patient, you can decide whether they have the level of immunocompromise. If the patient is an adult, so more than 6 years of age, any patient with CD4 count of less than 200 or less than 15% in children less than 6 years of age is considered to be severely immunocompromised, and all the guidelines or the contraindications which apply for an immunocompromised patients will apply to in these patients. But if the patient is having about 200 CD4 about 200, that is the age of 6 or more than 6 years, or more than ideally more than 25%, at least 15 to 20% of the CD4s of the overall lymphocyte, then we can consider them as immunocompetent. So general principles, first and foremost, what we are going to discuss is the various the live vaccines. Then what are the vaccines, or what is the situation if the patient is having CD4 count of less than 200, travel vaccine, and in the general contraindications. So in general, the general principle what we have learned is the live vaccines are contraindicated in HIV, but it is not so for all the patients, as I have shown based on the CD4 count. That is, if the patient is having CD4 count of less than 200, it means the patient is severely immunocompromised, and replicating vaccine, that is live vaccines, are not recommended because of the risk of vaccine associated disease. Then between 200 to 350, it is moderate immunosufficiency. And so based on the risk and based on the risk and the safe, the outcome which we are expecting, we can suggest vaccination. And other thing is, we should not be co-administrating multiple replicating vaccine as we can do in other patients. Because we have not, there is no study which has evaluated this. And a minimum of 4 weeks interval between vaccine is advised. And the standard contraindication for whenever the CD4 is less than 200 applies for the HIV patient. So it's whenever patient is having CD4 count less than 200, live vaccines are contraindicated. Even response to the non-replicating vaccines are slightly reduced. So that definitely, if the patient, so it doesn't mean that any HIV patient who is coming to you vaccinate, you start the patient on ART, await for the immune reconstitution, then you can vaccinate. But there are certain conditions where we may not have time to wait. So depending upon the level of risk, consideration can be given whether to give early vaccination or delay the vaccination. And another concern is the vaccination is there in any role of vaccination and the viral load. So there can be transient, clinically non-significant increases in the viral load, but these are counterbalanced by the benefit of the vaccination, and this does not or should not prelude from giving vaccination to the HIV. So what are the vaccinations which are recommended for the people with HIV? So these are the general recommendations. So I've tried to combine all the society recommendation, that is British HIV Association, the Indian guidelines, Indian consensus, as well as CDC and WHO. So in general, these are the ones which are recommended. Again, you may prioritize the vaccination based on the patient's condition, the risk of the infection, and in India, definitely the cost of vaccination. So COVID-19, hepatitis A, B, HPV, influenza, meningococcal, pneumococcal, Tdap, and zoster. Again, there are certain nuances which you need to know, so which we will discuss now. First, coming to the COVID-19 vaccine, I think most of them would have been vaccinated by now, but just ensure the patients have received the COVID-19, because when the patients, when the general population was getting this COVID-19 vaccine, there was no recommendation mostly for the immunocompromised patients or whether they have received or not. So if they have not received, definitely vaccinate them with at least 2 doses, depending upon Covishield, Covaxin, Sputnik, whatever is available. Next, hepatitis A. Hepatitis A definitely is required in patients who are children who are living with HIV. And there are certain societies which do recommend hepatitis A vaccine only in patients who have independent risk factor for acquiring hepatitis A, but the certain other guidelines do recommend hepatitis A vaccine for all. Next, talking about hepatitis B. So this was a scenario which I think we missed. A 50-year-old man with HIV presents to your clinic in routine care. He has been on TLD for the past 3 years and has an undetectable viral load with CD4 of 650. His HPS AG negative and anti-HCV negative. Which of the following is the most appropriate recommendation for hepatitis B vaccination in this patient? So can we have any responses in the chat? A, B, C, D, whether he should receive the vaccine only if CD4 is below 200. He should receive the vaccine. As he should not receive the vaccine as it's a contraindication in HIV patient. He should receive the vaccine only if he tests positive for HPSAG, and he should receive the hepatitis B vaccine as HIV positive are at increased risk of hepatitis B infection. So what do you think is correct? So I think there's some response. D, yes. So hepatitis B, so definitely, whenever your patient comes to you with HIV positive, you need to screen for other viruses, which hepatitis B is one of it. So HBV and HCV are screened for, and HBV usually you test only HBsAg, and HCV you test the anti-HCV, and if they are HPSAg negative, what are the other tests you need to do, and when do you decide to vaccinate? So basically, they are at higher risk of hepatitis B. As we all know, the transmission rate of hepatitis B is higher. But one thing we are safe, even if you don't test for it, is because the most often the ART regimen, that is the TLD, which includes the tenofovir, covers or treats for the hepatitis B. So, what is the indication for hepatitis B vaccination? Basically, people without chronic hepatitis B infection, without the immunity to the HBV. That is, you have to check basically the HBsAg, anti-HBC, IgM, and anti-HBs titers. So, if all of these are negative, then you will be providing them or giving the vaccine. And the vaccine response is better if the CD4 is more than 350. But again, this should not differ you from giving at lower CD4. You can always repeat the or give an extra dose. And you should check for the conversion at 4 weeks. And if they have not seroconverted, that is the anti-HBs titers is not more than 10 milliequivalent, you need to repeat or provide the boosters. So ideally double double quantity. Usually it is a 10 mcg. You can provide 20 mcg doses is recommended because of the poor seroconversion with routine doses. So you test for them, test for the HB evidence of immunity, then you can give the vaccine. HBV vaccine is very cheap. I mean relatively cheaper. It is around 80 to 100 rupees. Only concern in the past time was the non-availability, but again slowly it has it has become available again. So next, talking about HPV. So this is one vaccine which has been like a lot of people are talking about HPV vaccine in general public. Definitely, you should offer HPV even in HIV patients, or I would say especially in HIV patients, because they are at higher risk of this. And so, what is the recommendation? They say that any patient age above 9 years up to 26 years, you should recommend this. If nanovalent is available, that is Gardasil 9 is available, ideally you can use that. Otherwise, you can use the usual quadrivalent quadrivalent vaccine. And the use for in general population for ages 9 to 13, they do recommend just a single dose, and 13 to 26 2 doses, and above 26 3 doses. But in HIV, 2-dose series is not recommended. You need to give at least 3-dose series, that is 0, 1 or 2 months, and then at 6 months. And those who are above 26, that is 27 to up to 45 years, though the benefit is lower, you can always talk to the patient and you can provide the vaccine. And the cost of HPV vaccine, depending upon the availability, the quadrivalent vaccine is slightly cheaper. It's around 1,500 to 2,000. The nanovalent vaccine is costlier. It is around 8,000, 9,000 rupees. Next, the commonest one is the influenza. So, influenza vaccine is recommended for all the adults. I mean, it is definitely a recommended vaccine for all the adults, especially if the patient is HIV positive. And one of the contraindication is you should administer only inactivated influenza vaccine or recombinant influenza vaccine, not the live attenuated one, that is the nasal spray. This is especially indicated if there is a pregnant female who is HIV positive. And they would also do recommend high dose recombinant and adjuvanted influenza over 65 years over the standard doses. Next, the meningococcal vaccine. Again, the cost of influenza vaccine is around 2,500 and you have to repeat it annually. So next is the meningococcal vaccine. I think it is one of the least talked about or least used vaccine. It is recommended that they get a quadrivalent vaccine, that is MenACWY, and repeat vaccination every 5 years throughout their life. And men B, though it is not routinely indicated, it is recommended if the patient is having additional complement deficiency or asthenia, or if they are getting any complement inhibitors or during the outbreak scenario. So meningococcal in Indian context, I think most often they are just used in patients who are undergoing splenectomy. But again, this is also one of the life-saving vaccines. So I think it should be recommended more widely. The cost of meningococcal vaccine, that is Menectra, which is, can be around 3,000 to 3,500. Next, talking about the pneumococcal vaccine. So this was the scenario which I discussed in the pre-test. So a patient who is on ART, patient is having a suppressed viral load and CD4 is more than 200. So that usual sequence is you should give PCV 13 followed by uh, PPSV 23. So in a HIV patient, you need to give boosters of PCV 13, that is to at second month, fourth month, and sixth month. I mean, basically, then PPSV 23 should be administered at least 8 weeks after the last PCV dose. Next, talking about the Tdap. Tdap, again, this is also one of the recommended vaccine. Not only it is not only in HIV but in all the adults. So if they are vaccinated with the TT 10 years before, at least one dose of Tdap, that is tetanus, diphtheria, and pertussis vaccine must be given. And this is especially to be given in patients who are HIV with and pregnant women. So in pregnant women, what are the vaccines you will have to give is definitely Tdap, influenza, and COVID-19 if they have not received. Then talking about the zoster vaccine, this is again, I think it has been popularized by Amitabh Bachchan. So the shingles vaccine. So this was a scenario which you saw. So there are two types of shingles vaccine. That is the Zostavax, that is a live vaccine, whereas the Shingrix is recombinant zoster vaccine. So patients aged more than 18 with HIV should receive Shingrix, and adults with symptomatic HIV, you should not be giving Zostavax. But ideally, because it's a live vaccine, it is not recommended. But in patients who are aged more than 50 and having asymptomatic asymptomatic HIV in the sense there are the patient has been receiving ART, and on ART viral load is suppressed and the CD4 count is more than 350, you can consider giving Zostavax if the recombinant zoster vaccine, that is Shingrix, is not accessible. Again, and one more thing, you should notice Zostavax is only registered for use in more than 50 years. So in the scenario, it was a 45-year-old man. Even if you didn't know about it, Zostavax should not have been given in this patient. And only thing which is precluding us from giving zoster vaccine in all HIV patients is definitely the cost. So basically, you have to give 2 doses 1 month or 1 to 2 months apart. So the cost for a single dose is around 11 to 13,000. So next is the common vaccine, measles containing vaccine, that is MMR. Again, in patients who are severely immunocompromised, that is CD4 less than 200 or less than 15% of the total lymphocytes, should not be getting any live vaccine, especially measles containing vaccine. And those who have, in children, basically you give a 2-dose schedule at 12 months and 18 months. If the child is having less than 750, that is less than the usual recommended 15 to 20% of the CD4, then you can give the vaccine 12 months and 18 months, but you need to repeat the dose or give additional dose after the immune reconstitution. In adults, you should look for the titers, the vaccination titers. If there is immune response, if there is no, you need to repeat the vaccine, maybe 1 or 2 doses. So, summarizing the following, so in the live vaccine, so basically there is no contraindication for giving any recombinant or subunit other vaccines. Only thing which you need to be careful is about the live vaccine. So, patients having CD4 of less than 200, MMR, varicella, live attenuated typhoid, and yellow fever are contraindicated. But what are the absolute contraindications are live attenuated influenza vaccine, live cholera vaccine, and Japanese encephalitis, the live Japanese encephalitis vaccine, and oral live attenuated typhoid vaccine. So next, in Indian scenario, what we are worried about is the TB. So will you recommend giving BCG? So again, it is a live vaccine. So there is while the other guidelines, that is the British Society as well as CDC and WHO strongly recommend no, that a patient or an infant born or exposed to HIV should not get BCG vaccine because of the increased risk of disseminated BCGiosis. NACO do recommend should receive BCG at birth like any other infants. If the BCG is missed at birth and or HIV is confirmed early, you can delay the vaccine until the ART is initiated and the infant is immunologically stable. So definitely once he is immunologically stable, BCG again should be administered. Next, live vaccine which you can give is rotavirus vaccine and varicella vaccine. Rotavirus, especially, it has been included even in the, it as per the IAP, you need to give rotavirus even in the patients who are HIV. They are supposed to have good safety as well as immunogenic in the infant. Varicella vaccine, asymptomatic adults and children more than 12 months, they can get the varicella vaccine if they are sufficiently, they are not severely immunocompromised. So, just a note on vaccination in child living with HIV. They are definitely more susceptible and will have more serious complication. All inactivated vaccines can be given. Live attenuated is a contraindication, but again, as I mentioned, few of the exceptions do exist, like rotavirus. So this is the schedule for child living with HIV as per the NACO. So if you can see, most of them are similar in the similar lines according to the IAP. But again, I think I saw a question on oral polio vaccine. According to NACO, you can give oral polio vaccine once the patient is not severely immunocompromised. That is, CD4 count is more than 25% of the total lymphocytes. This is the Indian adult vaccination consensus. Again, that is an excellent document. So here again, if you see, they are recommending influenza, typhoid, Tdap, hepatitis B, pneumococcal, COVID, MMR, varicella, and HPV, shingles. But again, I would like to draw your attention to the recommendation rank, desirable. Just remember, these recommendation rank is not based on whether it is essential vaccine, it is a vital vaccine, but it is based on the community. How far or how much does a community benefit from this vaccination to the individual? So it is not based on the patient or the type of vaccine, whether that vaccine is definitely required or essential. So don't look at this column. Basically, these are the vaccines which you need to be giving in an adult HIV patient. This is the direct table from the BIVA guidelines, which again has a whole list of vaccines, and absolute contraindications are just according to the BIVA or the other guidelines is influenza, live attenuated influenza vaccine, BCG, smallpox, and live attenuated typhoid infection. So the absolute contraindications do vary depending on the type of guidelines. Just a short note on travel vaccine. Again, travel vaccine you need to depends on the destination, the itinerary, the length of stay, the planned activities, and these must be given important in all the patients in HIV positive as well as in those who are HIV negative. So this was a scenario which you got. So what are the vaccines you will recommend who is virologically suppressed? That is, now I think you must be knowing those who are not severely immunocompromised. What are the vaccine recommendation if they want to travel to sub-Saharan Africa? So the common vaccines, the must, that is a mandatory vaccine is definitely yellow fever, but you need to also vaccinate the patients for influenza, MMR, hepatitis A and B, DPT, and optional ones include typhoid and cholera. Polio also, again, I think I missed polio. Polio also is recommended for the patients who are going to Africa. The again, these travel vaccine is again an important topic. So polio vaccine is mandatory in especially Hajj travelers. So there are certain mandatory vaccines, but again, the other vaccines. So if there are someone is asking about what are the recommendations or what do you advise, you should recommend the vaccines based on the local risk and definitely the malaria prophylaxis. So yellow fever vaccine is one of the controversies in HIV patients, whether will you give a yellow fever vaccine. Again, in severely immunocompromised, um, you may not give the vaccine, and you can give a certificate for the patients, but who are not severely immunocompromised, you can give the yellow fever vaccine. So these are the other travel related vaccines which can be recommended or given in HIV patient. So last, is there any vaccine which you can prevent HIV? Again, currently there is no vaccines, but there are a lot of trials, and this is a topic for another day. So a bonus, this was the question which I had asked on monkeypox. Again, recently there was a lot of discussion about monkeypox. So again, it is just I had put it as a uh, uh, advanced learning. So monkeypox vaccine, as we all know, there are two types of monkeypox vaccine. One is live attenuated vaccine, and other one is the um, another one is the uh, killed vaccine. So the Genos vaccine is recommended in HIV patient where you give two doses, 0.5 ml subcutaneous or 0.1 ml intradermal, 4 weeks apart. And two doses, you are sufficiently protected. And they recommend there is no requirement of boosters. Boosters are only recommended in very special case like those who are doing research on orthopox virus or in mpox labs. So only contraindication is live replicating vaccinia virus, that is ACAM vaccine is contraindicated in HIV patients. So that brings us to the end of the my session. So if there are any questions, we can take up now, or if you have, you can unmute yourself and ask, or can leave in the chat box. Okay, I don't see any questions. So we quickly move on to the next session, next interesting session, that is vaccination in autoimmune rheumatic disease. So I invite Dr. Abhishek GP, who is assistant professor in rheumatology in KGMU Lucknow. So over to you, Dr. Abhishek.
Thank you, Dr. Akshita. Vaccination is an important part of healthcare system, and it is even more relevant in patients with rheumatic disease. Before moving on to the various guidelines which tell about the recommended vaccinations and the timings and the relative contraindications, I'll just briefly touch upon the burden of infections in patients with rheumatic diseases. The patients with rheumatoid arthritis or lupus have a threefold increased risk of pulmonary infection compared to general population. And 35% of patients with rheumatoid arthritis can have recurrent hospitalization due to pneumonia. Patients treated with methotrexate had a relative risk that is 10 times higher risk of developing pneumonia if they are not vaccinated. And the relative risks were 4.2 and 3.2 in patients with systemic sclerosis and Sjogren's syndrome. This is a large prospective Brazilian cohort of over 800 patients with rheumatoid arthritis. And they had an average follow-up of almost 1 year, and they documented around 90 serious infections. Serious infections meaning those requiring IV antibiotics as hospitalization or resulting in mortality. They could see that the risk factors were the presence of interstitial lung disease, which was associated with a threefold increased risk of serious infections, underlying chronic kidney disease, which was associated with 3.6 times higher risk of serious infections, and moderate dose of steroids, that is between somewhere 7.5 milligrams to 30 milligrams of prednisolone equivalent per day, that was associated with as high as 5.4 times higher risk of serious infection in patients with rheumatoid arthritis. If we look at various registries which look at the large data of patients with rheumatoid arthritis, the standardized incidence per 100 patient years was around 1.5. Now, when we want to look at the risk of infections in patients with lupus, there is a large Spanish registry called as the Restless Registry, which had more than 3,500 patients with more than 10-year follow-up. There, they could find that almost 20% of patients had serious infections, and the most common sites were the bloodstream infections, and more than 50% of those infections were due to bacterial infection. And the most common site was respiratory, that is the lung, in almost 35% of cases, followed by urinary tract infection and soft tissue infection. And almost one-fourth of the mortality were attributable to infections. Coming to the INSPIRE cohort, that is a multi-center cohort of lupus patients in India, which had more than 1,300 patients with a follow-up of more than 7,000 patient years. Here, almost 25% of patients had major infections, and the most common infection was Mycobacterium tuberculosis. In 81 patients, that it was the etiology. And the incidence of serious infections was 6.1 per 100 person years. And here also, almost 70% of the cases, infections were due to bacteria, even though majority of them were not cultured. And when do you get infections in patients with lupus? The most of the infections acquired in the first year of illness. In a Chinese cohort, almost 94% of the major infections occurred in first 4 months, and it was associated with mortality. The shorter the duration, it is an independent predictor of infection in patients with lupus. And it was also associated with higher mortality, and infections itself can increase the disease activity, thereby necessitating higher use of immunosuppressive therapy and further leading to increased risk of infections. This was a study of infections in patients with systemic sclerosis. This was published by us this last year. And here we almost saw that almost 25% of patients had serious infections. And the most common infection again here was tuberculosis. And the most common site was lung. In almost 38% of cases, it was in the lung, followed by skin and soft tissue infections, because these patients have increased risk of digital ulcers, gangrene. So they tend to have more skin and soft tissue infections. And looking at the organisms, the E. coli was the most common isolated organism, mostly attributing to urinary tract infections, followed by staph aureus, leading to skin and soft tissue infections. And the patients with infections had a higher number of admissions due to active disease, with odds ratio of around 6.2, and they were receiving high immunosuppressive therapy with odds ratio of 5, and they had more digital ulcers with odds ratio of 2.5. And the patients who had infection had a high likelihood of death with the odds ratio of as high as 13. Coming to herpes zoster infections, the lifetime risk of herpes zoster in general population is around 25 to 30%, and patients with rheumatoid arthritis have a twofold increased risk of rheumatoid herpes zoster infection, and the lupus patients have fourfold increase. And the hazard ratio was higher in patients with myositis as compared to systemic sclerosis patients, that was 3.9 over 1.6. And patients who are younger and they are found to have higher disease activity and they receive more immunosuppression, so they are at a higher risk of developing herpes zoster infections. Why is it so that myositis patients have higher risk of herpes zoster? Because glucocorticoids increase the risk of herpes zoster in a dose dependent manner. So as compared to patients with systemic sclerosis, where we use steroids very sparingly, in patients with myositis or in lupus, we use higher dose, including pulse. So that is associated with increased risk of herpes zoster infection. And if we treat patients with JAK inhibitors, that is tofacitinib, baricitinib, filgotinib, the hazard ratio is somewhere between 2 to 4. And if you treat a patient with abatacept, there is no increased risk of herpes zoster, because the uh, virus zoster specific memory T cells no longer rely on the co-stimulatory signal from CD80 and 86. So abatacept inhibits the co-stimulatory signal of CD80 and CD86. So that is relevant only in the naive T cells, whereas the varicella zoster specific memory T cells doesn't require this co-stimulatory signal. So if you treat patients with abatacept, there is no increased risk of zoster infection. So vaccination is very important, because patients with rheumatic disease have a significant increased risk of infections due to the disease itself or the comorbidities or the treatment which they receive. And treat to target approach, where we go on to give more immunosuppression to achieve disease control early, it was associated with higher risk of infection. So vaccination, thereby, it will prevent infection, it will lower the hospitalization and reduce the emergency room visits, and also decrease the overall cost which the patients with rheumatic disease have to incur. So next I pass on this to Dr. Rajat Kumar Sahu, who is a senior resident in King George Medical College, Lucknow. Over to you, Rajat.
Good evening, sir. We will discuss now the adult vaccination in autoimmune rheumatic diseases. The listed vaccine in inactivated vaccines are diphtheria, hepatitis A, B, Haemophilus influenza B, then HPV vaccines, influenza, then Streptococcus pneumoniae, tetanus toxoid, parenteral typhoid fever. And under live vaccines, there are MMR vaccine, oral polio, oral typhoid, varicella zoster, and yellow fever vaccines. So these are basically the example of normal inactivated and live vaccines. And in rheumatology, before considering any vaccine, we should consider these three things. That is, number one is efficacy. So that is capacity of the vaccine to prevent infection. And immunogenicity. So capacity of the vaccine to induce humoral and cellular immune responses. But immunogenicity can or cannot correlate with the efficacy. Finally, safety. Safety, that means the vaccines we are giving, that should not have any major adverse outcome, or it should not aggravate the underlying rheumatic diseases. Now coming to the EULA recommended adult vaccines. So these are influenza, pneumococcal, herpes zoster, tetanus toxoid, hepatitis A and B, and HPV vaccine. The last update of EULA recommendation for adult vaccination in autoimmune rheumatic diseases had 6 overarching principles. So we will discuss each principle in details. So the first principle is vaccination status and indication for further vaccination that should be planned yearly by the rheumatology team. And while planning for this vaccination, we should consider these three things, that is inventory of a vaccination history, adverse events of the vaccine, and flares of the underlying autoimmune rheumatic disease following earlier vaccination. Then the second principle is it should be shared decision making. That means it should involve the rheumatology team and the primary care physician and the patient so that there will be increased vaccine uptake among the patient. Then the third principle is preferably be administered during quiescent disease. So why quiescent disease? Because the data in active disease is very low, and some diseases like juvenile SLE and rheumatoid arthritis patients, they have shown that there is a reduced seroconversion rate to influenza H1N1 vaccination, and also in rheumatoid arthritis patient there is decreased immune response to influenza A vaccine. Then coming to the fourth overarching principle. So if we plan immunosuppression in a patient, especially a B cell depleting therapy like rituximab, so we have to vaccinate the patient beforehand. And there should be a gap of at least 4 weeks before the rituximab and at least 6 months after the administration of rituximab. But again, important thing is do not delay the necessary immunosuppressive therapy in severe cases. So in life-threatening conditions, suppose we plan to give immunosuppression to the patient. In that case, there should not be this amount of gap. So we prioritize our severity and we should give immunosuppression therapy instead of vaccine. The fifth principle is live attenuated vaccine should be avoided during immunosuppression. So with a possible exception of two things, that is MMR booster and herpes zoster vaccine. Why? Because some study like juvenile idiopathic arthritis has shown that after using MMR vaccination, patient is on glucocorticoid or methotrexate that did not influence the antigen specific antibody concentration or seroprotection rate. And again in herpes zoster also, that also did not affected the seroprotection rate. And it was a study involving Medicare beneficiaries with with autoimmune rheumatic diseases.
Rajat, you are not audible.
I think there is some connection issues. Dr. Rajat, are you with us? Okay. Let's try. So in the meanwhile, while Rajat reconnects, I have an announcement to make. So I'll be having a next CME. So it's on 1st of February as a part of World Aspergillosis Day. So the CME is a short CME which will be from 6 to 8:30, which will have experts from critical care, pulmonary medicine, microbiology, as well as ID. So these are the tentative topics. So we will have some interesting cases, then definitely about invasive aspergillosis in non-neutropenic and in critical care ICU setting, and the significance of aspergillus species identification and ABPA as well as CPA. So look out for it, and I hope you people will be interested in these webinars. So let's see if we can we have Rajat with us back again. Dr. Abhishek?
I'm trying to connect with him.
So in the meanwhile, any questions till now? Anyone would like to ask about any specific questions related to the vaccination in HIV?
He'll be joining in 1 minute.
Okay. I think he's back. Dr. Rajat, are you with us? Would you like to continue, Dr. JP?
Yeah, I think he's
Okay.
taking some time, so I'll just continue with this.
Yeah.
So, except for herpes zoster vaccine and MMR vaccine, so live vaccines are to be avoided in patients with immunosuppression. So he has told about MMR vaccine. When it comes to herpes zoster vaccine, the we could find that patients who were aged 60 years and above, there was no increased risk of herpes zoster after vaccination with herpes zoster, and live attenuated herpes zoster was safely provided to a small patients of a small cohort of lupus patients also. So it was relatively safe in patients, few of the small cohort of patients with lupus, and also in patients who are aged more than 60 years, they could easily take herpes zoster vaccine. So, coming to the after the overarching principles, coming to the 9 recommendations, here 9 of those recommendations are same as the 2011 guidelines, and 3 old recommendations are deleted regarding the hyposplenic and asplenic individuals, and the about the BCG vaccination and about the travel vaccines, and two just a second. And two new recommendations regarding the vaccination in household members and the newborn vaccines. Vaccination in newborn has been added. So coming to the first recommendation, so influenza vaccination should be strongly considered for most of the patients. Like just like the Dr. Akshita said, influenza in HIV, even in patients with rheumatic diseases, influenza vaccination has to be given, except if the patient is on rituximab. Now, a temporary discontinuation of methotrexate for 2 weeks before and after the seasonal vaccination actually was found to increase the immunogenicity. But however, it is not recommended to stop methotrexate just for giving influenza. If the disease activity is controlled, then you may consider stopping methotrexate when you give influenza. Otherwise, you can give influenza vaccine when the patient is taking methotrexate. And a second booster vaccine with seasonal vaccine with a pandemic influenza vaccine improves the immunogenicity, and the adverse effects were comparable to the healthy subjects. So when do you give? So we have to give before it is advisable to give before the onset of monsoon months, that is somewhere between April to May. And in temperate climates, that is in the extreme hilly areas like Kashmir, Chennai, or Vellore, it is advisable to give between September to October. However, our patients come to throughout the year, so it might not be possible to do it in all the cases. So I'm just checking if he joined. Okay. Rajat, have you joined?
Yes, sir.
Okay, you want to continue from here?
Yes, sir.
Yeah, okay. I had come till the influenza vaccine. This was the first recommendation. Over to you,
Yes,
Rajat.
sir. So sorry for the inconvenience. So when to give influenza vaccine? So the proper time is actually before monsoon months, that is April to May. But in temperate climates, extreme northern hilly areas like Kashmir, Chennai, and Vellore, so the proper time is September to October, and it contains a very small amount of egg albumin. So it can be given to the patients having egg allergy, and the adequate response takes around 2 weeks. And live vaccine should be avoided to the household members also. So if close contacts of immunocompromised patients given live vaccines, then avoid contact for at least 7 days. Then coming to the pneumococcal vaccine. So there is a strong recommendation of pneumococcal vaccine in autoimmune rheumatic diseases. And it has been shown that even in rheumatoid arthritis patient on methotrexate or biologics, they can provide adequate immunogenicity and protected antibodies 7 years. And it has also been shown that a relative risk of 9.7 in rheumatoid arthritis patient on methotrexate to develop pneumonia in non-vaccinated patient. And again, in cryopyrin associated periodic fever syndromes, so these are autoinflammatory syndromes, they may develop some local reactions and systemic reaction to PPSV23. So it has to be given very cautiously in autoinflammatory syndrome. Then coming to the pneumococcal vaccine types, so broadly it is divided into two categories. One is polysaccharide vaccine and the second one is polysaccharide conjugate vaccine. So conjugated, that means protein is conjugated with the antigen, whereas polysaccharide means antigen is attached to a long chain of carbohydrate. And this specific polysaccharide conjugate vaccines like strains 13, 15, 20, these numbers are representing basically the type of strain they are protected. And the basic difference between the polysaccharide and conjugate vaccine is, first thing is T cell dependent immune response, which is present in conjugate vaccine. Immune memory, so definitely it will be more in conjugate vaccine. Effectiveness less than 2 years. So in less than 2 years, we can give conjugate vaccines rather than polysaccharide vaccine. Then efficacy, so definitely high efficacy in conjugate vaccine because this is T cell dependent. Then post-booster immune response and IgG class switch. This will be very much high in conjugate vaccine again because this is T cell dependent immune response. This is the basic structure of the vaccine as we discussed, polysaccharide vaccine and conjugated vaccine. So A showing polysaccharide vaccines. So that means antigen is attached to a long carbohydrate chain, and this is only B cell mediated, no T cell mediated immunity here. So only B cell mediated, so there will be decreased memory and decreased immunogenicity. Whereas B figures showing polysaccharide conjugate vaccines. So here two things are there. One is polysaccharide mediated. So this is T cell mediated. So T cell mediated immunity will be there. And again, T cell will help the B cell to produce immunogenicity antibodies. So here memory will be very efficacious. Then the carrier protein. Again, the carrier protein specific T cell activity as well as B cell activity will be there. So producing more antibodies and more immunogenicity, which was neglected before in the polysaccharide vaccine, which is present in polysaccharide conjugate vaccine. So that is called the neglected valency here. Then coming to the pneumococcal vaccine schedule. So in any patients without any history of pneumococcal vaccine, so we can give PCV 13 followed by PPSV 23 with a minimum gap of 8 weeks. This 8 weeks gap is only for the rheumatic disease patients or autoimmune rheumatic disease patients. This is usually 1 year for the normal population. After 5 years from the PPSV 23, we can give another dose of PPSV 23 booster. And finally, the third PPSV 23 after 65 years. There is a recommendation to give single dose of PPSV 23 after 65 years. But here the thing is, the gap between two PPSV 23 should be minimum 5 years. Then in PPSV 23 immunized adults, suppose a patient is immunized with PPSV 23, and now we are planning for to give PCV 13. So there is a gap of minimum 1 year. And then the usual rule follows, that is 8 weeks, then PPSV 23, and minimum duration of 5 year gap, then PPSV 23, third dose, and that is after 65 years. And if PPSV 23 we are giving in the subsequent doses, so again 5 year gap should be maintained, and from PPSV 23 to PCV 13, 1 year gap is maintained. Then what are the causes of poor antibody response to PCV 13 and PPSV 23? So usually the causes are early disease onset, older age, high disease activity, immunosuppressive therapy, and then prime boost strategy. What is prime boost strategy? Here there are two things. One is prime. So priming with PCV 13, because this is the polysaccharide conjugate vaccine. So a single dose is very much efficient because this is T cell dependent. And then boosting with PPSV 23 subsequently with 3 doses, that will increase the immunogenicity. So in patients with rheumatoid arthritis, inactivated influenza vaccine can be given. Then other factors responsible for the decreased vaccine uptake. So this is a Immunovax RA trial where 192 patients were there, with 47% were more than 65 years, 59% were vaccinated against seasonal influenza, and 6% against pneumococcal. And 57% were vaccinated in the conventional DMARD group and 61% in the biological DMARD group. And the factors responsible were old age, lack of knowledge, low referral by the physician, and fear of adverse effects. Then the third recommendation was tetanus toxoid. So as per the general recommendation, it should be given, as well as passive immunoglobulin to the B cell depleting therapy like rituximab. So it has been shown that satisfactory immunogenicity in rheumatoid arthritis and SLE patients with DMARDs and rituximab received 6 months earlier. So that means a gap of 6 months after rituximab should be maintained. Then coming to hepatitis A and hepatitis B vaccine, it is recommended that hepatitis A vaccine should be given to the people resident of endemic countries. So 2 doses should be given 6 months apart. And if the patient is a last minute traveler, suppose the patient has been given a single dose and 6 months has not happened, so the patient is planning for traveling, so passive immunization prior to specific journey should be given. And in HPV vaccine also, there are certain risk patients like endemic countries, medical personnel, household contacts, sexual partners of known persons, then IV drug users, men sex with men, and always check the titer of anti-HPS antibody. If it is less than 10 milli international unit per ml, then boost before TNF inhibitors. So there is a gap of at least 8 weeks after the last dose. Percutaneous exposure to hepatitis B vaccine. So again, booster dose or passive immunoglobulin should be given. Then herpes zoster vaccination may be considered in high-risk patients with autoimmune rheumatic diseases. Again, we already discussed that Zostavax is the live vaccines, but that reduces infection in 51 to 70% among immunocompetent individuals. Reduce also incidence of herpes zoster over 2 years. It was present or conventional demand, and that protected for 5 years. And the a gap of 4 weeks before initiation of biological DMARDs or target synthetic DMARDs. And if there is uncertainty of varicella exposure, serostatus must be considered before administering live attenuated herpes zoster vaccine to prevent the active varicella infection. So 2019, Euler stated the importance of herpes zoster in autoimmune rheumatic diseases, but that lacked clarity and specificity. They advise to use herpes zoster vaccine cautiously, but does not specify the increased risk of herpes zoster in JAK inhibitors and glucocorticoid. So herpes zoster usually occurs due to reactivation of the dormant primary infection and due to the latency at sensory dorsal root ganglion, which increases with age, decreased cell-mediated immunity, and autoimmune rheumatic diseases. So there are two kinds of vaccine. Live vaccine is Zostavax, recombinant vaccine is Shingrix. Definitely, Shingrix is having superior immunogenicity and clinical efficacy compared with the Zostavax in the general population. So there is a strong recommendation to give Shingrix to more than 50 years. And it is also cost effective and recommended to immunocompetent individuals by the CDC. And patients with autoimmune rheumatic disease with a history of herpes zoster, especially patients with SLE and JAK inhibitors and glucocorticoid, which usually increases the risk of herpes zoster, they might still benefit from the herpes zoster vaccination. And then number needed to vaccinate the recombinant zoster vaccine to prevent one herpes zoster infection from the general population. It is around 11 and 12 for more than 50 years and more than 60-year patient. And there are usually two doses, IM doses, 2 to 6 months apart. And Zostavax is to be given at least 1 week before conventional DMARD and one dosing interval before biological DMARD. So single dose is sufficient as this is a live vaccine. So a question is, 58-year patient with rheumatoid arthritis had history of herpes zoster 3 years ago. Now planned for Zostavax before starting adalimumab. So what should be the schedule? So the answer is basically cannot be given because Zostavax is a live vaccine and that cannot be given within 5 years of active herpes zoster infection. Then coming to the vaccination against yellow fever. So it is a live attenuated vaccine. Antibodies usually develop 4 to 7 days post vaccination, and it should be avoided in patients with autoimmune rheumatic diseases. And in traveling to endemic countries, withholding immunosuppressive therapy to allow a safe vaccination. If the disease is controlled, then hold the immunosuppressive therapy, give vaccination, and travel with safety. And in previously exposed patients, that may also consider serology. Serostatus must be considered in previously exposed patient. Then coming to HPV vaccine, as ma'am already discussed in HIV patient, it is also similar here. But there it is 3 doses recommended, but it is similar to the normal population. So 9 to 14 years, 2 doses with 5 months gap, and more than 15 years, 3 doses, 0 dose, then 1 to 2 months, then after 6 months. And the minimum interval between 2 doses, first and second is 4 weeks, and second to third is 12 weeks, and first and third should be 5 months. And 27 to 45 years, that is a shared clinical decision making. So depending upon that, these patients can be vaccinated. Again, bivalent is Cervarix, quadrivalent is Gardasil 4 and 9. Then the 8th recommendation is vaccination of household members of AIRD patient. This was a new recommendation added in 2019 Euler. So the household members should receive inactivated vaccines and as well as live attenuated vaccines like MMR, rotavirus, varicella, and zoster vaccine. Oral polio vaccine should be avoided due to a risk of transmission to household members. And highly immunocompromised patients should avoid handling of diapers of infants vaccinated against rotavirus for at least 4 weeks following the administration of the vaccine. Then the 9th recommendation, it was also newly added. So this is vaccination for the newborns of mothers treated with biologics. Avoid live vaccines in the initial 6 months if mother treated with biologics in the second half of the pregnancy, especially more than 22 weeks. If it is less than 22 weeks, then the children can be given. The safest biological, if given, that is Tocilizumab pegol, that is due to the risk of least placental and breast milk transfer. Then coming to the 2022 ACR guidelines for the vaccination in rheumatic diseases. So the first thing is more than 65 years. with rheumatic disease patients, giving high dose or adjuvanted influenza vaccination is conditionally recommended. High dose means 4 times the antigen content in the general doses, and adjuvanted influenza, so a adjuvant is added. Basically, MA59 is added to enhance the immunogenicity. Then the second is age less than 65 years, pneumococcal vaccination is strongly recommended. Then more than 18 years, recombinant zoster vaccine is strongly recommended. That is the differentiating point from EULAR. It is, and also CDC, which recommends more than 50 years. Then more than 26 years and 45 years, HPV is conditionally recommended. So multiple vaccinations on the same day usually avoided, rather than giving each individual vaccination on a different day is conditionally recommended. Then this slide basically showing non-life attenuated vaccine administration with different conventional and biological demands. So the overall recommendation is conditional recommendation. If the disease is allowing, then we can stop the methotrexate 2 weeks before vaccination. That will increase the efficacy. But it is not a hard and fast rule that we have to stop the methotrexate. Again, similar for rituximab also. And for other non-life attenuated vaccines, you can continue methotrexate, and time of vaccination for when the next rituximab dose is due, then hold rituximab for at least 2 weeks after vaccination. Then with steroid or glucocorticoid doses, also there are some recommendation for giving vaccination, like influenza vaccine and other non-life attenuated vaccines can be given to the patients on less than 10 mg prednisolone. 10 to 20 mg, there is a conditional recommendation to give vaccine. But if more than 20 mg, influenza vaccine can be given. Again, conditional recommendation, but other non-life attenuated vaccines has to be deferred. And this is the slide basically showing live vaccines during immunosuppression. The general rule is we should avoid live vaccines during immunosuppression, but with some exception, that was MMR and herpes zoster. So there is a time gap between that is before giving vaccination and after giving vaccination. So usually it is 4 weeks is the holding time for immunosuppression after giving live attenuated vaccine. And the holding time before giving for immunosuppression before giving live attenuated vaccine is different for different drugs, like glucocorticoids. That is 4 weeks. Again, the glucocorticoid dose should be less than 20 mg. Then we can give the live vaccine. And methotrexate, again, the dose is specified, less than 0.4 mg per kg should be given. Then azathioprine less than 3 mg per given 3 mg per kg. Then we can give the live vaccine. And it is almost 4 weeks and calcineurin inhibitors. For JAK inhibitors, it is 1 week. And most of the biological, it is almost 1 dosing interval. And for rituximab, it is 6 months. And for IVIG, different doses have different holding time, like 300 to 400 mg per kg, it is 8 months. And for 1 gram per kg, 10 months, 2 gram per kg, 11 months. This is the list of vaccines according to the manufacturer and the price. Basically, in influenza, there are quadrivalent vaccine, trivalent vaccines, subunit and split vaccines. What we normally use is Influvax, so that is a trivalent subunit vaccines. And the usual cost, the current price is around 1800 rupees. And pneumococcal vaccine, again PPSV 23 and PCV 13. PPSV 23 price is almost 1800, whereas for PCV 13 it is around 3000 rupees. PCV 15-20 are not available in India. And herpes zoster, again the live vaccines and the recombinant vaccine. Recombinant zoster vaccine Singrix is costing around 10,000 rupees, and the live vaccine is around 9,000 or 8,000 rupees. And for HPV, also Gardasil 9 is 9,300, and 4 and Cervarix around 3,500 to 4,000 rupees. So the lifetime cost analysis of each vaccine in AIRD should be considered. For HPV, it is around 7,000 to 30,000, and for pneumonia, it is around 8,000 rupees, and for hepatitis, it is very low price, that is 300 to almost 1,000 rupees. Then IRAVAC expert consensus on adult vaccination. So IRAVAC is Indian Rheumatology Association Vaccine Expert Consensus. So this is very much similar to the EULA recommendation. but it also allows anti-rabies vaccine along with the tetanus toxoid when necessary, irrespective of the disease status. Inactivated vaccines has to be given irrespective of the severity of the disease, whereas EULA recommends it has to be given in quiescent disease. And this is what we follow in our day-to-day practice, because we have studied the EULA recommendation, ACI recommendation. So infection play an important role in mortality and morbidity in AIRD in developing countries like India. So common vaccine is are similar only, that is influenza, pneumococcal herpes zoster, HPV, hepatitis B, and tetanus toxoid as recommended by EULAR and ACR. So better to give in quiescent disease, but can be given in life-threatening conditions also, because most of our patients come with acute conditions only. And live vaccines definitely to be avoided, with exception of MMR and Zostavax. And the interval between vaccine and immunosuppression should be maintained, but immunosuppression should not be delayed in case of high disease activity. So proper dosing schedule should be followed again, as single dose vaccination does not protect from infections. Live vaccines are to be avoided till 6 months in infants, born to mothers with exposure to biological after 22 weeks. And again, financial constraint is a major issue in our countries. So, but the expenditure due to multiple infections, due to lack of infections, is also very high. We can advise influenza yearly before basically monsoon months. PCV13 once in a lifetime, because this is a live vaccines, T cell mediated vaccines, but not live vaccine, that is a polysaccharide conjugate vaccine, but T cell dependent. But it should be given as soon as possible before 65 years. PPSV 23, 3 doses. So 5 years gap to be maintained between the doses, and 1 dose after 65 years. So PCV 13 after 8 weeks, PPSV 23, and PPSV 23, then 1 year gap, then PCV 13 should be given. So Singrix 2 doses, 2 to 6 months apart, minimum 4 weeks gap should be maintained between the 2 doses. And recombinant zoster vaccine can be given irrespective of the previous herpes zoster infection and live herpes zoster vaccination status. That means if live vaccines has been given or any active infection has occurred, recombinant zoster vaccine can be given. And hepatitis B, tetanus, and HPV vaccines, these are given similar to the immunocompetent individuals. So these are basically CDC recommendations. This is specifically for all those immunocompetent individuals, and also for rheumatic diseases, and also for CKD, liver disease, and alcoholic patients, and some immunocompromised patients. Here for pneumococcal vaccination, if a patient has already received, not received previously PCV 13, 15, 20, then we have options for PCV 15 and 20, but these are not available in India. Again, previously received PCV 13, then we have options for PCV 20 and PPSV 23. Then coming to contraindications. So there are no absolute contraindication as such, but history of anaphylactic reaction is there, allergic reaction is there, so it has to be considered. Any acute infection, so we should avoid vaccination. Live vaccines in severe immunocompromised conditions, these are the usual and relative contraindications of vaccine. There is a syndrome called ACS syndrome, that is basically autoimmune and autoinflammatory syndrome induced by adjuvant. So the adjuvant we add to the vaccine to increase the immunogenicity, that can also cause some adverse events called ACS syndrome. So that can cause fever, myalgia, arthralgia, sore throat, and headache and dizziness. So the criteria for ACS syndrome is exposure to an external stimuli with typical clinical manifestation, and removal of the trigger leads to improvement. Also, minor criteria involves autoantibodies and specific HLA and autoimmune diseases like sarcoidosis, Sjogren's syndrome, UCTD, immune-related adverse events. So coming to the question, why 1 year gap between PPSV 23 and PCV 13 is there? So although this is not an hard and fast rule, but the possible explanation is highly efficient antigen presenting B cells, which are also the antibody producing cells, may be busy in responding to the recently administered PPSV 23, because PPSV 23 is a T cell dependent, B cell dependent vaccine, whereas PCV 13 is T cell. So if we give PPSV23 and give PCV13 without a 1 year gap, those B cells used in PPSV23 cannot act if we give PCV13 again. Then 60 to 65 per patient needs to be vaccinated for pneumococcus. What should be the schedule? Again, the general rule applies here: PCV13, then after 8 weeks PPSV23, after 5 years PPSV23, but no further doses. Usually we give PPSV23 3 doses, but the last dose is after 65 years and that is a single dose. Then 72-year patient came for pneumococcal vaccination with prior PPSV23 at the age of 66 years. So what should be the schedule? So answer is no vaccination needed, because already the patient has crossed 65 years and also received PPSV23 after 65 years. Then 66-year patient, history of PPSV23 at the age of 63 years, now came for pneumococcal vaccination. What should be the schedule? So definitely after 5 years. So we can give PPSV23 at the age of 68 years. So coming to the summary, vaccination protects against serious infection in AIRD, so thereby decreasing mortality, morbidity, and rate of hospitalizations. So ultimately reduces the disease flare also and helps in sustained remission. Every recommendation like CDC, ACR, and EULAR, they recommend 6 vaccines in AIRD: influenza, pneumococcal, herpes zoster, HPV, tetanus toxoid, and hepatitis A and B. And ACR recommends Shingrix more than 18 years, whereas EULAR and IRAVAC recommends Zostavax more than 50 years. IRAVAC considers vaccination irrespective of the disease activity, whereas ACR and EULAR recommend in quiescent stages. CDC recommend vaccination in general populations like CKD, CLD, heart disease, HIV, and other patients. Check for always acute infection before vaccinations, and adverse effects to be kept in mind always. Thank you.
Thank you, Dr. Rajat. Thank you, Dr. Abhishek. It was a very insightful and very precise and in such a short time. So I think it has clarified a lot of our doubts regarding the vaccination, when to give the vaccine, when to start the vaccine, what are the vaccines which need to be given based on the immunosuppressants or based on the biologics used. So now I open the forum for questions. If there are any questions, you can either ask in the chat box or you can unmute yourself and ask the question. Dr. Abhishek, do you have any concluding remarks?
Yeah, I bring back to the same first statement. Vaccination is extremely relevant in our patients, especially because there will be an immunosuppression and they are at a high risk of getting serious infections, which lead to the increased mortality. And live vaccinations, as such, is almost contraindicated except for MMR and zoster vaccine. And steroids is particularly associated with higher risk of zoster infections. And all the inactivated vaccinations, especially the influenza and pneumococcal vaccination, has to be given because the risk of mortality with the pneumococcal infection or the influenza infection, especially in patients with underlying lung disease like interstitial lung disease, is extremely high. So it is always advisable to give pneumococcal vaccine, and with the upcoming use of frequent use of JAK inhibitors, the risk of zoster infection is also increasing. So now we are getting some companies who are trying to give the recombinant zoster vaccination. That will be a very helpful in our patients, because Zostavax is very difficult and costly for us to give. So I think these are the very relevant things I would like to say.
Yes. So I see there are a few questions. One of the questions regarding the talk with what do you recommend in my practice for the HIV vaccines? So again, one of the major issues is definitely the cost. So keeping in mind the cost, other thing you should worry think about is, rather than the cost, are at the time when you're giving the vaccine, is like you can convince the patient, like just how you take a life insurance or health insurance. A vaccine is like an health insurance you're purchasing, so it will prevent you from further expenses which may need to spend after, if at all you get an infection, and you may have, they will definitely develop severe infection requiring ICU admissions and so forth. So you can convince the patient in that way. Other thing is, so we do definitely vaccinate for influenza and pneumococcal. So the cost will be around 7,000, 7,500 with these three. This vaccination, like in PCV 13 followed by PPSV 23 and the influenza vaccine. And hepatitis B vaccine is very cheap, so around 80, 90 rupees, 3 doses, around it will be 240 rupees. So definitely these three vaccine. And Tdap, at least 1 dose of Tdap, again that is not very costly. It's around 500, 600 rupees. So uh, so these are the vaccines we do definitely advise and give in the patients who are HIV. And special risk factors, if that patient HIV is a diabetic as well, so in they are much at much higher risk of herpes. So in that case, we do counsel the patients, but again we cannot insist because Shingrix is cost prohibitory. Like around, they need to spend around easily 20 to 25,000, which we cannot expect. So we do counsel and ask them. So those who are affordable could take the vaccine. Okay. I think there is a question by Dr. Arvind Motagi. What is to Dr. Abhishek or Dr. Rajat? What is the importance of giving hepatitis A, B vaccine in immunoglobulin received patients for prevention of myositis or immunosuppressive disease? Would you like to take up this question?
I'm actually not clear with the question. It says prevention of myositis. There's nothing called as prevention as such. I agree that the various viral infections have been attributed to the increased risk of autoimmune diseases like the EBV, CMV, parvo infections, and various other infections said to be associated with the increased risk of autoimmune diseases. But as such, infections itself cannot cause the autoimmunity in majority of the cases. The most likely cause being the molecular mimicry. And when it comes to hepatitis B, the patients are more prone to get a medium vessel vasculitis that is called as polyarteritis nodosa. And with the hepatitis C infection, there is something called as cryoglobinic vasculitis. As such, for other diseases like myositis and all, they are all usually multifactorial. Both the viral infections, environmental, lifestyle, smoking. Actually, smoking is very important factor which has been implicated in various autoimmune diseases. So yes, infections do increase the risk of in various autoimmune diseases, but it is established very few diseases like the polyarteritis nodosa or the cryoglobinic vasculitis. In myositis, there's no much direct evidence which we can say. So
Okay.
definitely, vaccination will be helpful to decrease the burden or the risk of autoimmune diseases. Uh, it need not be to just myositis.
And again, sir, for the vaccination for hepatitis B, it is not recommended to give in all patients of myositis. They have recommended to give in only the at-risk population. So not in every and each and myositis patients we are giving the hepatitis B vaccine. And in response to, if any, we are planning certain immunosuppression like TNF inhibitors. So not in only myositis, which are the hepatitis B, then we should give, and then we should check the titers also. And if it is less than 10 milli international unit, then we should give.
Okay. I hope it answers your question, Dr. Arvind. So if I can ask, like, what do you, I like what, so we learned about the various recommendations. So I would like to ask, what do you actually practice? Like, is there any vaccine you give, or how is the uptake of vaccine in your patients? Any,
Definitely,
yeah,
we will counsel the patients to give influenza vaccine and pneumococcal vaccine very regularly. Zoster vaccine is not actually easily available, so it is very difficult. If somebody is really apprehensive about zoster infections and if they can afford Zostavax, then in such scenarios we are using it. Otherwise, these two. And if it comes to the tuberculosis, we are routinely doing Mantoux and the IGRA before starting patients on biologicals, especially anti-TNF therapy and even rituximab. Almost all, even in like few demands like cyclophosphamide, we do testing for Mantoux before, so that we decrease the possible we just give an empirical treatment for the latent tubercular infections, and we try to get down the risk of tuberculosis, because in both the patients with lupus or with systemic sclerosis, the most common infection was tuberculosis. So being in an endemic country, we are bound to find tuberculosis as a common DD. It can even present with various rheumatic manifestations. So definitely we will be chasing pneumococcal infection, influenza, and tuberculosis. Others, we are trying to incorporate.
yeah. I think the hepatitis B vaccination is one of the like low hanging fruit, though it may not be ideally recommended in the patients, you know, like HIV patient. It is a general recommendation for all, so that can be easily given. Um, so again, the I think the topic on TB is latent TB and treating latent TB in Ritux. It's a quite debatable topic. Maybe we can save it for any other next session. Um, Next thing I would like to ask is like, is there a specific reason we give see, PPSV23 has 23 different antigen, whereas PCV13 has just 13. So why not give PPSV23 only, or give preferably PPSV23 over PCV13? So it is not my question. It has been asked by like a few of the colleagues before. So I would like to know your opinion on that.
It's conjugate vaccine, so the immunogenicity will be higher, even though it covers only 13 serotypes. And there's something called as PCV20. So actually, it doesn't require any booster. So if we can afford and get PCV20, we need not have to take multiple vaccines for the prevention of pneumococcal infections. So we are going by the convention that conjugate vaccine gives a high immunogenicity. So that is why we are going with PCV13, and followed by after an 8 weeks gap, we are going with PSV23.
Okay, thank you. So I think that brings us to the end of the session. I don't see any further questions in the chat box. So I think we can call it a day. So we'll have monthly session like this. So next month with a new topic in the Rheuma-ID Crosstalks. And again, I would like to reiterate, like the February 1st, I'll be having the CME on the World Aspergillosis Day. So yeah, I think we'll uh, end the session here. Thank you all for joining, and looking forward for your presence in other talks. Thank you. Thank you,
Thank
Dr.
you.
Rajat
Thank you.
Sahu, for being a
Thank
part
you.
of this webinar, and I hope you had a good time and it was a wonderful session. Thank you.